to talk today a little bit about the work that we're doing in the laboratory in trying to develop a biological disc replacement, and in particular for this talk about how we're trying to generate annulus tissue that we can use to perhaps repair some of these defects. So we heard a lot already about the annulus. It's a very complex tissue. It's composed of up to about 25 lamellae, in which they are rich in collagen and organized in altering angularity so that they form a radial ply type of tissue. If you damage the annulus, it has very little capacity for repair, and we saw a beautiful image from Roger today showing that large defect. And so the current methods of repairing this defect, suture, glue, pins, have really not been very successful. So there's been a growing interest to try and grow these tissues in the laboratory in an attempt to fill in that defect. And so that's what we've been doing in the lab. And we've taken a two-pronged approach. Firstly, we've characterized the tissue that we're actually trying to repair so that we can try and generate the right kind of tissue. We've studied a bit about development, and we're trying to use those pieces of information to create a tissue that more closely mimics the native tissue. So, the annulus fibrosus can be divided into two parts, an inner and outer annulus. And in the outer annulus, you can see that the lamellae are separated by an interlamellar space. The annulus surrounds the nucleus pulposus and anchors the two vertebral bodies together, so it has lots of functionality that all needs to be restored. It's really important to be able to visualize the disc so that we can understand what it is that we're trying to recreate. So I'm going to try and take you through this. So these are histological sections, and these are from bovine discs, and we've been studying bovine discs predominantly because that's probably the model that we intend to utilize to test our constructs out. But in addition, it turns out that the bovine disc has lots of similarities to the human disc. So we can learn a lot from this tissue. And so what we know is that the inner and outer annulus have different compositions and therefore look somewhat different. And you can see here the inner annulus and here the outer annulus with the lamellae. And the inner annulus, you don't see that lamellar differentiation as clearly because there's abundant extracellular matrix, this proteoglycan-rich substance, which stains with this toluidine blue stain. And you can see clearly here the delineation between the outer annulus and the inner annulus. And you can appreciate that as we start to age, and these are just adolescent discs, we're already starting to lose matrix from the inner annulus. The annulus has also got a very complex composition. So not only is it architecturally complex, it's compositionally complex. And this is just an annulus stained for various different components, the three major components that are present in the annulus, the type 2, type 1 collagen, and the proteoglycan aggrecan. And as you see, as you progress from the nucleus out towards the outer annulus, and you can see here in this trans-illuminated image the lamellae of the outer annulus, that the type 2 collagen is predominantly present in the inner annulus and starts to dissipate as we go out laterally. In contrast, the type 1 collagen is more prominent in the outer annulus and starts to decrease in amount as we go in towards the nucleus. And as I've already mentioned, the aggrecan is present in the inner annulus with very little aggrecan present in the outer annulus. And so this composition all has to be reproduced in the type of tissue that we're going to regenerate if we want it to function properly. So not only do we have the issue of making the right kind of tissue, but how are we going to anchor it? So we need to understand how the annulus inserts into the vertebral bodies in an attempt to see if we can actually reconstruct that. So this is just a low power magnification of the disc, and what you can see is the outer annulus, the inner annulus, and the vertebral body. And you can appreciate that it's obviously interrelated to the bone, But you can only really appreciate it if we look at it under polarized light microscopy, because that's the technique that allows us to see the collagen, which is the major component of the annulus. And the collagen is this refractile material, and you can see the nice lamellae in the outer annulus, and in the inner annulus it's not as clear because of the abundant proteoglycans. But what you can appreciate at this magnification is that in the inner annulus, the collagen fibers are inserting directly into the bone, whereas in the outer annulus, we have a mixture. We have collagen fibers going into the bone and going around the vertebral body and merging into the lateral aspect. And you can appreciate that better at higher magnification. And just to orient you, we're looking at this region here, and you can see in the inner annulus the collagen fibers inserting directly into the calcified end plate. And you can see it much clearer in this magnification, where you can see the collagen fibers merging directly into the bone, which is this portion right here. So in the inner annulus, the fibers are going directly into the calcified end plate. As we start to go laterally towards the outer annulus, and we're looking at this area here, you can see that the collagen fibers now in these outer lamellae are inserting directly into the calcified end plate, but there are lamellae that are coursing around the outside. And it's actually really quite complicated, because what's happening is that these lamellae start to split up into the collagen fibers, which you can see very clearly here on this polarized light microscopy, into individual fibers that are coursing down. So we have a portion of the lamellae that's going into the bone, and a portion potentially that is going around the edge of the bone. And if we continue to follow it down the side of the vertebral body, here you can appreciate by polarized light microscopy the annulus lamellae and the fibers here, and they are all merging to the periosteum perichondrial aspect of the vertebral body. So clearly the insertion of the annulus is very complex. And clearly we have a real chore ahead of us. So if we start to characterize this interface more thoroughly, what we can see is the composition of this interface is actually also complex, which doesn't surprise us knowing how complicated the disc is in the first place. So this is a histological section in which we've stained it for either type 1 or type 2 collagen. And actually in these sections we've stained them together so you can visualize it very clearly. And this is the inner annulus, this is the outer annulus, and you can appreciate the type 2 collagen that's inserting into the calcified end plate. But you can also see that there's a lot of type 2 collagen in the interface between the outer annulus, which is, as we expect, type 1 collagen, which is the red staining, as the interface between the outer annulus and the calcified end plate. And as you go down around the edge of the vertebral body, this type 2 collagen persists. And that was something that really wasn't expected. When we look at this interface of the annulus with the bone, which is this pale blue staining tissue below, you can appreciate that the cellular composition of this interface is actually not straightforward either. We can see an admixture of these round cells, which are surrounded by these proteoglycans, indicative of chondrocytes. But in addition, there are these more spindled cells, which are the annulus fibrosus cells, and they're present in the collagen fibers that are migrating or extending into the calcified end plate. And interestingly, this interface goes on to calcify, and you can appreciate here a blood vessel growing into this interface and the surrounding bone. And this whole area will calcify and form that thickened subchondral bone that you might see in the intervertebral disc. Well, clearly this tissue can calcify, and so we looked for molecules that are indicative of mineralization, and not surprisingly, we found it. These cells express type 10 collagen, which is a marker of mineralization, at this interface only. We didn't see it up higher in the annulus tissue. And we also found that these cells have alkaline phosphatase activity, which is this blue staining, so that this whole region, And this is the annulus, and this would be where the calcified end plate would be if we hadn't dissected the tissue off of it. And so at this interface is rich in this alkaline phosphatase. So this tissue has the potential to mineralize, and it is this tissue that goes on to form the calcified thickening of that end plate. So we have a complex tissue. That's a big challenge. So we thought that perhaps the best way to go about regenerating this tissue would be to learn something from developmental biology and determine if we could recapitulate that organization or development, would we be able to form a properly organized tissue? And that was a tall order, as you can appreciate now, given the complexity of this tissue. So there has been a very nice study by Tony Hayes and his group in the late 1990s in which they looked at development in the rat disc, and they were actually able to point out some important features. One is that the rat disc, early in development, expresses an integrin, an alpha-5 beta-1 integrin that is present on the surface of these cells, and that these cells start to align, and as they organize themselves, they start to express actin stress fibers, and they also express fibronectin filaments. And that's not really important to you, but it's important to me because it's those presence of those molecules that lead to properly organized collagen fibers, which is critical for an annulus. So we know a little bit about what we were aiming to achieve. And so then we start to look at the development of the disc in humans. Very early on in the annulus, you can see very early in the first trimester that the cells are already starting to organize. And you can see that better in this high magnification. You can see the cross-hatching of the cells, which we know is ultimately going to give rise to the angulated lamellae of the annulus. And even at this early time point, there is collagen produced by these cells, and that's this refractile white lines, but it's not very organized. But during this first trimester, the annulus undergoes a complete organization, as you can see here, of aligned lamellae. And these lamellae then grow with age. So what are we going to try and mimic? Well, clearly, trying to do this by tissue engineering was really going to be a tall order. So we chose to try and mimic this aspect of the annulus development in the hope that we could generate a tissue that would be more closely similar to the native annulus. So how did we do that? Well, the first thing that we did with my colleague Paul Santerre was determine the appropriate biomaterial or scaffold material that would allow us to give us that aligned, organized structure, because clearly that was what we were going to have to try and mimic. So he developed a method to electrospin polyurethane, and that results in this membranous type of material, which when you examine at higher magnification has this very aligned structure. And these fibers have a size that mimics that of collagen. This material is elastic, which is a feature we would want from it. It's biodegradable and has mechanical strength similar to that of a single annulus lamellae. And importantly, we can layer these membranes so that it can potentially give us the organized structure and angulation that we require from the annulus. So the next thing we had to do was take the scaffold and get it to support tissue formation. Well, we know that the cells have a very specific orientation, and we know that to attain that orientation, they have to express certain molecules. And we also know that the environment that these cells are in can profoundly affect that development. So the first thing we did was take the scaffold, which is just a polyurethane, and coat it with a number of different factors. This is just a summary of that work. But we coated it with fibronectin, we coated it with collagen, a mixture of the two. These are things that are present, as you know, in the disc. And what we found was that we could profoundly influence the orientation of the cells. So when the scaffold was coated with fibronectin, we got these elongated, aligned cells. When it was coated with collagen, the cells were round and polygonal and had the wrong shape. And we could actually just quantify that by measuring the cells. And what you can see is that the cells on the fibronectin are much larger than the cells on the collagen-coated scaffolds, and the mixtures obviously in between. So we had a adhesive agent that we knew would generate cells that had the proper orientation. Well, the question was, would it result in these cells expressing the right molecules that will result in aligned collagen? So the next thing we did was look to see if these cells express the right integrin, the alpha-5 beta-1. And what you can see in this image, which has been stained with an antibody specific for the alpha-5 beta-1, that the cells on the fibronectin-coated scaffolds express this integrin, whereas the cells on the collagen-coated really express very low levels of this integrin, very low or none. Then the next question we asked, well, these cells are aligning, they've got the right integrins, are they going to start to make those fibronectin fibrils that are an integral part of developing oriented collagen fibers? Well, I wouldn't be here telling you the story if we didn't find what we wanted to find. And when we looked at these cells and we stained them with an antibody to detect fibronectin, what we found on these cells is the formation of those fibronectin fibrils that were a key component in the developing rat disc are also present and made by these cells. And you can see them here on this cell. So we went on to ask the next question. The cells are aligned, they're doing the right thing. Are they now going to align their collagen fibers in the same way? And so we stain these cells with an antibody for type 1 collagen, and that results in this green staining that you can see here. And lo and behold, we weren't really surprised, but what we found was that these cells also secreted a collagen that was aligned appropriately, parallel to these annulus fibrosus cells that are making their integrins, fibronectin fibrils, and also expressing those actin stress fibers that are very much a part of all of this developmental process. So we had a scaffold when coated with fibronectin, generated a cellular organization that said to us would be likely to generate a tissue that might be appropriate to use for annulus repair. So the other question we needed to ask was, the cells were aligned, it's making a matrix, but are these cells retaining their phenotype? Are they making the right kinds of collagens? Are they making, do they have the potential to form that mineralized interface that's going to be required? And we were able to demonstrate that when these cells are isolated and grown under the appropriate conditions, they express alkaline phosphatase, which is the red staining, and you can quantify that. So we have cells and the appropriate culture conditions that will allow us to do all the right things. So we took this scaffold and we've layered it into a multi-layered structure and grew it in the culture in our laboratory. And here you can see the type of tissues that we're starting to generate in this voyage that we've undertaken. And this is just a tri-layer scaffold, and we've gone now as high as 7 layers. And you can see that the cells are aligned and producing a collagen-rich matrix, as indicated by the blue staining. And we can generate these multiple layers, which have increasing mechanical strength. So, can we generate an annulus fibrosis repair patch? Well, we're on our way to being able to accomplish that. We still have clearly a lot of work left to do to be able to accomplish this, but we feel we've identified the conditions that will make that trip much faster. So thank you very much.
So I'll talk about minimally invasive versus open discectomy. As mentioned, the surgical treatment of lumbar disc herniation is generally speaking very, very successful. It's really one of the most successful operations that we do as spine surgeons. And it really relies on surgically gaining access to the disc. And then if you look at this image here, if you have a herniated nucleus pulposus, removing the offending part of the disc fragment and decompressing the nerve root. And that is being done as it is with a relatively minimally invasive approach, even the standard approach. However, I will talk a little bit about what, in addition to that, less invasive or minimally invasive surgery can maybe add to that. Now, we've got pretty good evidence that surgical treatment of herniated lumbar discs is a very successful intervention. Just as an example, the study by Weinstein, the SPORT trial, demonstrated that in a large number of patients, that surgery resulted in greater improvement compared to with non-operative treatment up to 4 years after intervention. So we pretty much know that. Now, let's talk about minimally invasive spinal surgery and what that really means and how that may improve our results on the existing surgery. That has been reviewed recently, and I think a very reasonable definition has been offered. Minimally invasive spinal surgery is a procedure that, by virtue of the extent and means of surgical techniques, results in less collateral damage, so less damage to the adjacent muscles, bones, ligaments, and so forth, in a measurable decrease in morbidity, a more rapid functional recovery than traditional surgical exposures, without differentiation in the intended surgical goals. Now, I want to also point out that this is theoretical. We don't know this for sure. We don't have proof that we actually really achieved that. But that's what we want to get, and that's what we have in mind if we try to learn, adopt, and introduce less invasive surgical techniques into our surgical practice. So the principles rely really on trying to avoid the muscle injury that is frequently associated with traditional spinal surgery. That's an MRI scan after a discectomy. You can see that high intensity signal here indicating that there's a certain amount of atrophy of the muscles associated with the surgical approach. So we want to try to avoid muscle injury by muscle splitting approaches using self-retaining retractors. So rather than making a big incision, cutting the muscle, pushing the muscle out of the way, we're trying to split the muscle by keeping the muscle, the innervation, the vasculature, and so forth as intact as possible, by limiting the width of the surgical corridor. So instead of making a huge incision, while we really only need a very, very small opening, try to really limit the incision to the size of the opening that we actually really need, using known anatomic, neurovascular, and muscle planes that are present in the lumbar spine and also in the cervical spine. And we try to avoid a disruption of tendon attachments of key muscles, particularly the multifidus muscles and other muscles in the lumbar spine. All I'm talking about today is really also lumbar spine. I'm not going to really talk a lot about cervical spine. This has been recently reviewed by Chol Kim very nicely and summarizes really the main principles that we use when we talk about minimally invasive spinal surgery. Now, the purported benefits of minimally invasive spinal surgery are pretty obvious. Obviously, cosmetically small incision, there's less surgical trauma. We've got pretty good evidence that the infection rate with currently being used minimally invasive surgery in the spine is very, very low. Blood loss is low. We've got pretty good evidence for that. Less postoperative pain that has been shown after minimally invasive spinal fusion surgery, discectomy, laminectomies. Patients get in and out the hospital usually faster. The cost issue is completely different. That has not been evaluated sufficiently. Same or better outcome. We certainly don't have class 1 evidence, but I think for certain pathologies we can say that we have at least similar outcome as for traditional open surgery. Now, from a surgical perspective, there's a few things that have been accomplished over the last 20, 30 years in various areas of surgery, not only spinal surgery, but really orthopedics, plastic surgery, ENT surgery, and so forth. All these areas have developed expertises in different fields that we bring together as minimally invasive spine surgeons to really make less invasive spine surgery possible. We have access strategies now using percutaneous techniques such as endoscopes, for example, mini open like tubular retractors that have allowed us to get to parts of the spine that we really couldn't get to with that minimally invasive approaches before. We've become microsurgeons. The microscope was introduced in spinal surgery in the 1960s, 1970s, and nowadays we've become extremely comfortable operating under a microscope. Some surgeons prefer the endoscope, but this is also a microsurgical tool frequently now. Navigation, whenever we do minimally invasive spinal surgery, we lack the anatomical landmarks. We don't know exactly where we are because we just cannot see the surrounding anatomy. So some type of navigation becomes extremely important, fluoroscopy, stereotactic navigations, and so forth. And then finally, in collaborating with companies, with technical engineers, we've been developing implants, instrumentation devices that allow us to do a lot of these big operations much more elegantly with less invasive surgery. This is a study that was published a few years ago looking at laminectomy patients, but using the tubular retractors. And you can see, and this is just representative for a lot of the other studies out there, that the blood loss, if you compare the traditional surgery to the minimally invasive, the tubular surgery, the blood loss is significantly less. The mean operating time is sometimes the same. In this case, it was less. And then certainly patients tend to go home much earlier. Microdiscectomy goes home the same day, even up to 2-level laminectomy patients now. If they're medically fine, they can go home the same day. There's very minimal blood loss. Now, this was taken then obviously to the next level, and a group out of Europe started a prospective randomized trial using the tubular retractor for microdiscectomy surgery here, which is illustrated here. You use these dilators, you put a tubular retractor in. That's a picture of what the surgical site looks like compared to the standard microdiscectomy using a different type of retractor where you scrape the muscle of the bone so you don't dilate the muscle. So essentially what I talked about before, trying to really test whether this type of minimally invasive surgery for this type of operation, for the microdiscectomy, actually gives you a benefit. Now, to make a long story short, 328 patients were included, 1-year follow-up. There was no difference in outcome. There was actually one of the outcome parameters at 1 year looked worse for the tubular surgery than for the open discectomy. And there are many reasons why that may be, but I think as a minimally invasive spinal surgeon, I was obviously shocked, and I was at the verge of giving up my practice. However, if you look back, then I think part of the problem is that I think we were a little bit too aggressive as minimally invasive surgery, claiming that we would really expect a difference. If you look at the type of the incision, the type of surgery, I think it would be very unlikely to actually really be able to see a difference, because even the standard surgery is very, very minimally invasive as it is. So after that, I wasn't really that surprised anymore. However, I want to share with you a few reasons why I think that there's still a benefit to less invasive tubular surgery. And I want to go through those advantages that I strongly believe in. So what is still the rationale to still consider doing tubular microsurgeries? Well, the main reason is that a lot of the surgeries that we do are not microdiscectomies. We treat on patients with spondylolisthesis, with lumbar spinal stenosis. All of those are still widely open. And I would claim that in those areas where the traditional operation is much more extensive, less invasive surgery actually will really give you a benefit. And we're waiting for randomized controlled trials to be done and hopefully show that. I still think that minimization of muscle and soft tissue injury is being provided by these tubular retractors. I'm convinced that there's less blood loss. Patients go home the same day. One of the main advantages that tubular decompression surgery versus open traditional surgery can provide you is that you minimize the destabilizing effect of an open laminectomy. So I think in laminectomy patients, lumbar spinal stenosis patients, there's a distinct advantage of tubular surgery, and I'll try to show that to you. And I think there's also, from a technical standpoint, as a surgeon, what the tubular surgery allows you to achieve is an excellent contralateral decompression under the facet joint. And I'll give you a few examples. Now, this is a patient, a 60-year-old female with degenerative spondylolisthesis, with a severe lumbar spinal stenosis. Based on the currently available guidelines that we frequently use, this patient would be a candidate for a decompression and fusion because she's got spondylolisthesis with severe lumbar spinal stenosis. Now, and I think that we can avoid a fusion if we use less invasive surgery. The standard surgery is being done with an open laminectomy where you remove all the posterior elements, do a wide decompression. With a tubular decompression, we don't do that. We leave all the posterior elements intact. The spinous process, the ligaments between the spinous processes are intact, the muscle, and so forth. So we cause less destabilization. This is a decompression after a tubular laminectomy. And therefore, I think that we can frequently treat these patients without necessarily having to do a spinal fusion, as long as they don't have any other overwhelming evidence of instability, such as severe mechanical back pain, instability on flexion extension films, and so forth. And I think that this is a real possibility for us to save healthcare dollars and really improve these patients' outcome. All of this that we're doing at my institution, we're doing with very detailed follow-up in terms of radiographic follow-up and outcome parameters and so forth. This is just from the operating room. This is a tubular retractor in use. We use bayoneted instruments under the microscope. We use the operating microscope for all of these procedures. And then this just gives you a contralateral view. Now, looking from the right side across the thecal sac over to the left side, you can see that you can get an excellent exposure, even on the contralateral side, sometimes even better on the contralateral side with these tubular retractors. And where does that become important? Now, this is a patient who comes in with a disc bulge and a foraminal disc herniation. On the sagittal image here, you can see that at L4-5, that exiting L4 nerve root is severely compressed. Now, this compression is right under the facet joint. It's very difficult to treat with open surgery without really removing part of the facet joint and sometimes causing instability. With a tubular access from the contralateral side, by tilting the table and tilting the tubular retractor, you can very nicely and very elegantly get across the thecal sac and actually take, and this is looking under the microscope from the right side over looking towards the left side. You can look at the exiting L4 nerve root and completely decompress that nerve root with micro instruments in the operating room without destabilizing the spine, without having to take any significant part of the facet joint. So I think that's what tubular surgery kind of allows you to do. This is, this has been described in the past. This is from a publication from Asia. Foraminal disc herniation, the access from the contralateral side, and you have like this window that you're looking through between the spinous processes that gives you a perfect visualization of the contralateral nerve root. In my opinion, a great way to treat this type of pathology that sometimes would require a much wider decompression and sometimes even a fusion. However, there's a learning curve, and I made the mistake that, I've only been practicing for 8 years, but I made the mistake that I started collecting outcomes immediately, and but the nice thing is that I was really able to see a learning curve. Over 4 years, the operative times have significantly decreased with tubular surgery. We looked at about 225 patients. We looked at recurrent disc herniation rates with tubular surgery. We also looked at our surgery times and outcomes in obese patients. And generally what you see, there's a tremendous learning curve. The number of CSF leaks goes down, is virtually zero now. And it's like everything else that you start doing for the first time. It takes you a while to really get good at that. What about complication rates? The AO actually had a publication where they looked at complication rates in studies comparing minimally invasive versus open surgery, looking at CSF leaks, infection rates, and so forth. And there was no difference between open versus minimally invasive spinal surgery complication rates. We looked at obese patients, comparing non-obese to obese patients with tubular surgery. One of the biggest challenges for an open surgeon is a microdiscectomy in a very obese patient. Requires a huge incision sometimes. There's significant blood loss. Same for laminectomies. With a tubular operation, it doesn't matter. The incision is the same. It's actually sometimes easier to do it in bigger patients. And so I think that certainly in those patients, there's a big advantage of tubular decompression. Now, just summarizing, what are the common spinal pathologies that we see, and how does that relate to minimally invasive spinal surgery? I think disc herniation, MIS is possible, but clearly there's no big advantage of what we consider minimally invasive now towards the standard operation, which already is a relatively less invasive operation. However, Now you start talking about lumbar spinal stenosis. Routinely, we do 2 levels decompression with a tube. The patients go home the same day. You can do that with the endoscope. I haven't done that, but some surgeons do. I think we need to look at the outcome data, and we really have to kind of get a better understanding whether tubular surgery is an advantage. I'm pretty sure it is. Spondylolisthesis, so grade 1 to 2, routinely done with tubular decompression, percutaneous screws, navigation in the operating room. Patients do very, very well. I think that's certainly an indication where minimally invasive surgery is going to show some benefits. We've published fusion rates, open versus MIS fusion rates. Those are identical. Complication rates are actually lower with less invasive surgery. So I think that's something we have to look into further. And then finally, foraminal stenosis, the contralateral decompression, sometimes very difficult to treat with conventional surgery. With tubular surgery, it becomes a very straightforward problem. I don't want to downplay this, but that's what it looks like to me. Degenerative scoliosis, very difficult to treat. I think with some of the lateral approaches that we have for lateral fusion X's with percutaneous screws and tubular decompression. Concluding, endoscopy for discectomy, maybe that's the way to make it less invasive, but I think that the discectomy that we're doing currently is already doing a pretty good job. I think tubular and percutaneous procedures may replace many more invasive procedures in the future. It allows treatment of patients who were not really considered good surgical candidates in the past. For example, degenerative scoliosis in older patients, I think, is an example. The principles rely on muscle-sparing approaches, decompression without destabilization. I think that's one of the main advantages of these less invasive surgeries. Indirect decompression with the lateral, the XLIF approach, for example. Contralateral decompression for the foraminal stenosis that I mentioned. And then stabilization, navigation, microsurgery. This have all evolved over the last decades and allow us to do a lot of these things. However, we don't have any class 1, we don't even have class 2 evidence except for that discectomy study that trashed us as microsurgeons. However, we need to get more evidence, obviously, for a lot of these other pathologies. So thank you very much for your attention.
So this is a typical patient, 35-year-old male with new onset low back pain and right L5 radiculopathy. The right leg symptoms are the predominant symptom. And they do have mild ankle and toe dorsiflexion and eversion weakness. And so they come to you, let's say, several weeks out and want to know exactly what they should do or how they should be treated. And of course, the dilemma becomes, are they going to be somebody who, if you don't intervene, ends up with a fairly prolonged and perhaps even lifelong problem versus being someone like this patient who within several weeks to months of their disc herniation, or diagnosis of disc herniation, has had a gradual relief of their symptoms, and you can see that a follow-up MRI shows a resorption of the disc herniation. And it's very difficult to differentiate which path these patients will go towards, and the data will help us to some extent. So these are the questions that I face most commonly. So obviously, should I have surgery? Secondly, well, after you explain all the risks and benefits and what we think we know at least, well, I'm still not sure. So is this a decision I really have to make now? Is there going to be a consequence if I decide not to have surgery and then need it? And obviously the potential for permanent nerve damage. I'm not talking about someone who comes in with a foot drop or a severe weakness, but just someone who's got radicular pain, let's say, and some mild weakness potentially like the patient I just described. Will discectomy also help my back pain? You know, my back pain maybe isn't my primary problem, but it's pretty substantial. I can't imagine living like this for the rest of my life. And everybody says, well, it'll help my leg pain, but not my back pain if I have surgery, and that's maybe not as desirable as I'd like. How much disc are you going to remove? Do you take out the whole thing? That's a common question that I get. Won't I do better if you use a tube? I heard people are doing tubes now. That sounds pretty cool. Won't I do better if you do that? And are there any long-term effects to dural tears? When we talked about the risks, you said something about the CSF leak. That sounds bad. What if that happens? What are going to be the effects? And what kind of limitations am I going to have after surgery, and for how long? Because I really can't afford to take a ton of time off of work right now, and so that may impact my decision. So let's start first with, should I have surgery? And there's really, obviously, there are tons of articles that have been written about this topic, but really the two best sources of quality data are two prospective trials that have been done, one in the Netherlands, the Hague Spine Intervention Prognostic Group, and they have various publications, as well as the SPORT trial that I think you're all familiar with and that we've already heard about today. And so looking at the first group, the Dutch group, in 2007, they published a prospective randomized study, so high-class evidence, 283 patients, and they compared patients who'd had symptoms for 6 to 12 weeks. Okay? And they compared either early surgery, which was within 6 months, versus non-operative treatment and surgery if needed for a greater than a 6-month period. And what they found is what we already more or less, I think, appreciate. They confirmed that the leg pain improved faster. They're looking specifically at sciatica in this article, or at least focusing on it. The leg pain improved faster with early surgery, and that was statistically significant. And but that at about a year, the results essentially normalized, where the non-operative group and the operative group actually had fairly similar results. So really, I don't think anything new relative to what we've known for years or suspected for years. They also then followed up with a 2-year follow-up study, and you can see the graphs here, and they showed that over the course of 1 to 2 years, there's really no difference. So you see the immediate decrease, or a fairly immediate decrease in pain in patients with, or in disability, I should say, pain, leg pain, back pain, in patients who had early surgery, but that the patients who had conservative treatment, well, they sort of gradually caught up, and by 1 year, they were more or less caught up and stayed the same. Within 2 years, which is the range of this particular study. The SPORT trial at this point published a 4-year prospective multicenter study. They actually had 2 groups. They had a prospective randomized group, and they actually had a larger observational group simply because some patients, they felt it would be of value to participate in the study, and the researchers wanted them to participate, but they wanted to choose their treatment. They didn't want to be randomized. And so there are separate arms that were, on the one hand, pooled together in the analysis, but on the other hand, also analyzed separately. So an observational and a prospective group, and various outcome measures have been used, and pain measures have been obviously evaluated repeatedly over time. And so looking at the simpler of these two to look at is the observational group, because either patients had surgery or didn't have surgery, right? And so in this particular population, you can see that when you look at the ODI, there was a substantial, almost immediate improvement in ODI, and then it stabilized over time and persisted over time, whereas again, much like the previous study, the Dutch study, there was a gradual improvement, a more gradual improvement in the ODI in patients who were treated non-operatively, but it never really caught up, and there was still a substantial difference. And so based on the observational group themselves, you would argue that this idea that over time, we're looking at 4 years here, the idea that over time patients who have surgery and patients who don't have surgery have more or less the same results may be flawed. And patients who have surgery may do better overall. Now, interestingly, if you look at it gets a little more complicated if you look at the randomized group, because they don't only include the patients who had surgery, at the bottom here, and didn't have surgery, but they include all the intent to treat patients, meaning the patients who they intended to treat these patients surgically, the white circles. They intended to treat these patients non-operatively, or they were randomized that way, I should say, rather than intent. In the triangles, and then because you had crossover, because you had patients who chose to then change the type of treatment, it sort of confounds the data and makes things a little less clear. So I would say what this suggests is that there's a good possibility that surgery will give patients a better result, but it's obviously not definitive, just like with any study. And oftentimes another question I get asked is, well, you know, if I'm going to have surgery, if I'm not really improving, I'm going to have surgery, I'd rather just have it done now rather than wait it out. And so there are a couple of issues. First of all, that's obviously a time-consuming problem. Is what's the likelihood that actually I'm just not going to be able to take it anymore, I'm going to need surgery? Well, if you look at the Dutch study that I talked about before, they actually cited a 40% likelihood that patients who were randomized to the conservative side, to the non-operative arm, actually would choose to then cross over and have surgery within the first year, which is actually a pretty impressive number. And then an additional 4% within the second year. This is during their 2-year follow-up study. Which brings up the issue I brought up, that I discussed before. Will delaying surgery actually compromise the outcome? Maybe someone's willing to delay and wait it out, but not if it's going to mean having long-term problems that could be potentially avoided. And so these 2 studies came up with with really different conclusions, or similar but somewhat different conclusions. And looking at the patients I just discussed in the Dutch study who crossed over after a year or so. So now we're looking at patients who have decided to have surgery, but 6 months or later after the onset of their symptoms. And so looking at the patients who crossed over from who were randomized to the non-operative arm, what they found was that even though the patients who had early surgery had a more rapid relief of their symptoms, the patients who had later surgery actually caught up, and there was really no difference at 1 or 2 years between these groups either. So the conclusion of that study, that delaying surgery for 6 months or more up to 2 years, which is all they evaluated, actually didn't compromise the patient's outcome. However, the SPORT trial had different results. What they found was that indeed, if a patient waited more than 6 months, their radicular pain didn't improve to the same extent that it would if they would have had surgery earlier. But interestingly, their radicular pain also was worse off if they didn't have surgery. So basically, the whole curve was phase shifted to the left, meaning that surgery will still help them. They'll still be considerably better off than if they didn't have surgery, but they would have been even better off had they had surgery earlier. Okay. So will discectomy help my back pain? That's another issue. We always tell patients that this isn't surgery that's not designed for back pain. Obviously, I'm not talking about the patient who's had 20 years of back pain here and comes in now with a new onset. Is this someone who has, in conjunction with their radiculopathy, they also have low back pain? And actually, the SPORT trial is actually quite helpful in determining this as well. In fact, it does appear that surgical intervention does help with the relief of back pain. And we're talking about microdiscectomy here. So if you look at these graphs, you have the 4 groups. You have the patients with leg pain who were operated on early, okay? Or I should say who were operated on, period. These are patients who had leg pain but were not operated on, okay? Patients who had back pain who were operated on, and patients who had back pain who weren't operated on. And so what you'll see from that is that basically leg pain improved more than back pain regardless of whether patients had surgery, and that comes, I think, as no surprise to any of us. Surgery is likely to improve the back pain in these patients, but not to the extent that their leg pain will be improved, but it'll be improved more than non-operative treatment would, it appears. So getting now to the question, and Roger's already partly answered this, so I'm not going to dwell on this very much. The same picture from the same article that he was referring to. What about this tube thing? I mean, it sounds pretty slick. You put a tube in and you spread it, and you don't actually cut, right? You make an incision. That sounds bad. So, well, the issue is that it's basically the same exposure, just the retractor is different. The tube is a type of retractor, and then whether you use the various types of retractors, I don't need to name them. It's essentially the same dissection for discectomy, and I agree with what Roger says is when you're talking about fusions and additional procedures, well, then it gets different, and so that's maybe where we'll see differences in the outcomes. But essentially, it's exactly the same exposure with a different retractor, so I would expect to have similar results. And in fact, this is the same randomized trial, actually a pretty well done study out of Netherlands, same group I mentioned earlier, who looked at this particular issue. And what did they find? They found that, first of all, the skin incision's about the same, whether you use a tube or whether you use a retractor. Referring actually to other studies, that the MRIs with contrast are really not much different, or not really statistically different at all, if you're looking at patients who had the tube surgery versus a standard microdiscectomy, if you will, suggesting that there's not much difference in the damage or scar tissue formation in the muscle groups. And that their outcomes were in some ways similar, and all patients were fully recovered by 2 weeks. The concerning thing in this study is, as Roger suggested, that it suggests that patients who had tubular surgery actually did worse when it comes particularly. They actually did worse if you look at it in all of these measures, whether you're looking at the disability score, leg pain, or back pain. But there was a much more concerning difference when you're looking at back pain. So the suggestion, not just that using a tube, the so-called minimally invasive surgery, would be no different, but actually would potentially worsen someone's outcome, was disturbing. And obviously this is one study, but ultimately the way I interpret all this is that there's no difference simply because it's the same operation with a different retractor. Okay, and this is an example on the left of the tubular discectomy and a microdiscectomy on the right side. And here you have just a reference to the study that looked at the amount of scar tissue formation in the paraspinal muscles relative to either a tubular surgery or a standard microdiscectomy. There's really no difference between the two. So another issue that comes up, how much disc should you remove? How much disc are you going to remove? Are you going to take out the whole disc, or are you going to just take out a little bit? And I think the trend has been to take out less and less disc. I know in my training it seemed like the more old school way to do it was to really scrape out that disc with the thought that it would prevent recurrence. And so a couple of studies, not to dwell on them too long here, but a couple of studies, or several studies have been done to look at this issue, and been actually quite a good quality review study that was recently published in Neurosurgery that looked at essentially a review of ultimately cumulatively over 13,000 patients. And what they found was that in the short term, meaning within a couple of years, it really didn't make a difference. Whether you took out a bunch of disc or took out just a small herniated fragment and didn't probe around too much. However, when you're looking at longer term results, so greater than 2 years, there seemed to be a significant difference. If you took a substantial amount of the disc out, and that's defined in various ways, but essentially a more radical discectomy, you would basically have a 2.5 times greater likelihood of having chronic back pain. And so, of course, you think, well, that sounds like a bad idea. Why not just take as little as possible? But unfortunately, like everything in medicine and surgery, there's no free lunch. And in this situation, your likelihood of recurrence, or having a recurrent disc herniation, pretty much doubles if you do a limited or a more minimal microdiscectomy. And so these are the issues that you can discuss with patients when looking at the two options. And who knows what the right answer is. But I would probably tend to err towards taking a little less and avoiding chronic back pain and dealing with recurrences if necessary, because we know that patients tend to, and I don't want to steal Randy's thunder, but patients tend to have similar results with recurrent surgery as well. So Carrigy looked at this as well. He looked at it in a little bit different way. What he looked at was, first of all, recurrence rate as well. We're taking, they actually measured the exact volume, and this came out actually after the review paper, so I thought I'd comment on it as well. They looked at the exact volume and divided it sort of an over-under, where if it was less than such and such or more than such and such, what would the likelihood of recurrence be? And they looked at the disc height on repeat MRI scans at pretty frequent intervals, you can see. So what they found actually was that there was a much greater loss of disc height when more volume was removed, so when they were above the threshold of volume, and there was a higher recurrence rate with the less volume removal. So essentially similar findings, but in perhaps a bit of a different context. So talking about durotomy, we know what happens with a certain degree of frequency. Does it really affect long-term outcomes? And so even here the data is a little bit conflicting. I think this is the article, or one of the articles that I've relied on in the past to try to figure that out. It's a large series of patients, but the retrospective review, and what they found basically was that there were various, at 10-year follow-up, so fairly long follow-up, some considerable limitations that occurred as a consequence of an intraoperative durotomy, so it may not be all that benign. And I think many of us have kind of wondered and haven't seen, at least, sometimes if you don't ask, you don't see it, but really trying to be as objective as possible about your complications and your patient's result, haven't really seen that dramatic a problem with them. And the sport trial, I think, again, helped shed some light on this situation. Much higher quality data, 25 patients out of 800, so 3.1% durotomy rate. And what they found at a 4-year follow-up actually was that there were no long-term issues. The ones they looked at, as you can see, nerve root injury, post-op mortality, and any need for additional surgeries and various outcome measures. There was no difference at any of the 1, 2, 3, or 4-year measurement intervals between patients who had durotomies incidentally and those who hadn't. And the only differences had to do with technical issues like increased operative duration and blood loss, which is understandable, need for repair, et cetera, increased bleeding, and the increased length of inpatient stay, likely related to the fact that most of those patients will be admitted overnight at least rather than being sent home. So the evidence from the sport trial is that it's in all likelihood an incidental durotomy in general doesn't have a negative long-term outcome after microdiscectomy. So the last thing I'll talk about is postoperative restrictions. Often patients want to know when they can go back to work or resume their activities, their sports activities. And the issue, of course, is the thought that perhaps limiting activities will minimize the risk of a recurrent disc herniation during the time when patients are the most vulnerable. And this is from Carrigy's study. They had about a 10% recurrence rate, which is a little bit higher. Normally, what's normally cited is about a 10% reoperation rate total after microdiscectomies, with about half of those being due to recurrence. But he actually published a paper which I thought was a pretty good paper back at over 10 years ago now, looking at patients essentially who were given no activity restriction. They were self-limited, meaning if you feel fine, do it. If you don't feel fine, don't do it. And they were allowed to return to work whenever they wanted. A third of them returned to work within a week. Again, the average work absence that you can see is just over a week, and they found no correlation between early resumption of activities, or lack of restriction of activities is probably the better term, and reoperation or need for reoperation for reherniation, which is about 5%, which is about normal or typical for disc herniation surgery. And so these are the answers to the questions that I get asked, at least from my perspective of the literature. Should I have surgery? Well, if you'd like a faster relief of leg pain, then you should have surgery. If you think you can hold out, then that's probably a good idea to avoid surgery if you feel that you can move on, it's not compromising you too much. Well, I'm still not sure. Will waiting compromise the result? Well, that's a problem. It may potentially, some recent data suggests, more recent data suggests, and also older data has brought this to light as well, that delaying surgery can lead to a worse result, even though surgery down the road could still be of benefit to you. Will discectomy also help my back pain? In all likelihood, yes, it will. Not as much as your leg pain. How much disc should be removed? I guess that's difficult to decide. It depends on which, it's kind of one of those pick your poison scenarios. Which complication do you prefer not to have? And I would vote towards trying to minimize the risk of chronic back pain and dealing with recurrences as they occur, or if they occur. But that's, I think that's debatable and subject to opinion. Does using a tube make a difference? Certainly not for microdiscectomy, possibly for other uses. Are there any long-term effects to dural tears? Probably not. And what limitations be after surgery? Early return to work and self-limited activities. Thank you very much.
There's a couple ways of looking at reoperation following a lumbar discectomy. Any repeated surgery at the same level or any level, that's really not what we're interested in. Redo discectomy at the same level, same side, same level, different side. Whether or not that's recurrence or not is unclear. Whether or not symptom of sick disc is probably a little bit more solid. What needs to be done for it is a reasonable question. Or redo discectomy at a different level. I think really what we're focusing on here is same side, same level, and different side, same level. When we look at repeat surgery following discectomy of any flavor, we can look at a population-based study such as the Maine lumbar spine study, prospective observational study of all patients done in Maine presenting to orthopedists, neurosurgeons, and occupational medicine physicians. Treatment was determined by the physician. They had 80% follow-up at 5 years. What they found was about a 19% reoperation rate in that group, which is a general population-based study. And they found that the patients' outcomes were not as good with reoperation. They were significantly worse. This is a mixed bag of surgeries. It just merely speaks to reoperation after a discectomy. In that population, your 1 in 5 will have a second operation after a simple discectomy. Carlo quoted the SPORT trial, which was a very nicely done trial. As you know, it was very selective in its inception cohort. Had to be herniation at a level corresponding to the neurologic exam. They had to be considered a surgical candidate, and surgery was a standardized surgery as much as possible. They started out collecting and looking at their patient population. As Carlo said, the ones that didn't want to go into the randomized trial went to the observational cohort, and the ones that went into the randomized trial obviously were randomized. There were a lot of crossovers, but in general, when they put the database together, it was very useful for this topic because it was such a nice select population. They found a lower incidence of reoperation. Again, this is a different population, very screened, very select, and they found the reoperation rate of about 10%, of which half were redo discectomies at the same level. Doesn't account for patients lost to follow-up, doesn't account for those people who may have represented and been thought not candidates for reoperation, which is another unclear area, and it doesn't account for patients outside of the SPORT criteria, which probably makes a difference from the population-based study of the main study and this study, which was very patient selective. And this is a study that Dr. Flum alluded to this morning. It's pre-publication. It was an examination of the variation in operation rates following first-time disc herniation. It uses the Washington State Discharge Registry cohort, the CHARS, and hopefully we'll have better data in the future from the scope. Mean age was 47 and a half, had surgery between 97 and 2000. They found that the overall curve of reoperation rate fit examples from the literature. So Washington State was pretty much on the curve of reoperation rates. It suggested that there was a lot of variation between hospitals. The red is the quote-unquote benchmark from the SPORT trial, which as we see was a pretty selected study group, so it may not be an optimal benchmark. But there was reasonable variation around the mean. And then when you look at surgeons, there was quite a bit of variation among the mean. And there's obviously some reasons for that. That needs to be sorted out, and the scope might be the perfect tool to do that. But there was quite a bit of variation around that. So there's a lot of variation in technique. So it makes it a bit of a difficult thing to study here, and it also suggests that as our simplest and probably most effective surgery in lumbar spine, it's worthy of looking at, because there may be something that the patients on this end can teach the physicians on this end can teach the physicians on this end. But it suggests there's a lot of issues in these, and you can't just read the literature and read the abstract and get the right conclusion. You got to look at the classification scheme for the initial herniations, surgical technique, proper description of the inception cohort, and try to find validated outcomes. And these are generally missing in most of the studies. So we'll make the best of with what we can do. And this is bad for the studies, the upfront studies. The SPORT trial did a pretty good job, and so did the Dutch study, but even worse for the repeat studies. Now, as Carlo said, it's a pretty successful operation we have. Probably closer to 90, but somewhere between 60 and 90% of people get better. A wide definition of failure, but it does suggest that there is a significant population that doesn't get better, and that's really the population that we're interested in here. There's a lot of etiologies for failure: insufficient decompression, surgery at the wrong level, nerve root injury, persistent lateral or central stenosis, segmental instability that may be iatrogenic or not, wrong preoperative diagnosis, diabetic root infarction isn't going to respond to decompression, and reherniation of the disc. And we're going to try to pick out just the disc reherniation. That can present as a couple of things, as we've seen. Sciatica can come from true reherniation at a different level, epidural fibrosis, arachnoiditis, foraminal stenosis, not just reherniation. So you've got to make sure when they represent with sciatica that it's coming from the same level. You can always ask them, is it the same pain? And that's actually a pretty good indicator. But you, again, have to confirm it with imaging, and unfortunately, operating on epidural fibrosis doesn't have the same result as operating on a true reherniation. And then there's low back pain, which can result from a number of issues. When we're talking about repeated discectomy, we're talking about a very small population of that. There are a number of studies on that. One of them was done by Mike Haglund, who was here, and when he spent his time at the Atkinson Morley in London, he looked retrospectively at 55 patients from the English experience, third world country. Follow-up post-redo microdiscectomy, non-standardized outcome measures. Minimum follow-up was a year, and found sort of to set the general trend that the improvement was quite good, both in leg and back pain, similar to what you see in the first-time studies. So pretty good outcome in that study. One thing they did find was that the duration of symptoms more than 6 months after reherniation or reappearance of the symptoms was predictive of worse outcomes, which is consistent with other reports. So it suggests that when a patient has had a good result, comes back with new sciatica, you should work it up with alacrity, just like you would first time. Papadopoulos, again, a retrospective study, but had some at least construed controls. Looked at outcomes of primary surgery versus second surgery in a case control method. 27 redo patients out of a population of 57, which makes it a bit of a select population. Redo was, patients had to meet the criteria of having at least 2 months of relief from the original surgery. Matched for age, gender, surgeon, level, and length of follow-up. So pretty decent experimental design, and excluded for causes that weren't really in keeping with redo herniation or repeat herniation. Used the MODEMS outcomes approach, phone survey. It used the lumbar spine part of that. That's a musculoskeletal survey, relatively well standardized. Follow-up was fairly long-term. The interval to redo was 63 months from the first surgery to the second surgery. So these people were a ways out from their first surgery. What they found, again, was that the condition improved, and it seemed to improve about the same as with first-time disc surgery. Pretty successful, actually. What they found didn't seem to respond quite as well was low back and buttock pain. the musculoskeletal component of this. And they found that, as you might expect, that the sensory fibers didn't recover as well, which is consistent with compression of small, unmyelinated and partially myelinated fibers. So it makes sense, and you can tell your patients that the sensory recovery may not be as good, but that's not inconsistent with first-time surgery either. So they concluded that repeat microdiscectomy for recurrent lumbar herniation was quite a successful operation. The DIE study, which is often quoted in this, was a retrospective study of 39 consecutive redos. This illustrates the problems with these studies. A number of original techniques. The redo diagnosis may have included stenosis, and they did a whole bunch of repeated surgeries, a whole bunch of approaches. So this is not a study to quote, and I won't go into it, because this is more of an example of how hazardous these studies are. Now, the prospective study from Sinai and all was very interesting. Out of 365 primary discectomies, they had a 7.4% of reherniation. Retrospective control of 30 first-time discectomies as their control, but it was prospectively collected data on the recurrent herniations. And again, they had to have 6 months or greater relief from the first. They had to have recurrent radicular pain, unresponsive non-operative therapy, and they had to have recurrent herniation at the same level. This was done by the same group with the same technique. They used a mixed outcome. They aggregated VIS for sciatica and satisfaction, functional outcome measures, and physical examination into a 100-point scale. Follow-up at 6, 12, and 24 months. And they found no significant difference in outcomes between first-timers and redos. So again, a very effective surgery. This is an example of return to work data, and they showed not only that they were similar in outcomes, but that the response from before and after that original surgery were similar. And that's pretty much what they saw across the board. That's just the return to work data. Of the 4 redo patients, most of them had a reasonable explanation. One was a second reherniation, which was redone and did well. One had postoperative discitis, left with moderate back pain. 2 of them had only moderate improvement. What about contralateral reherniation? This is another thing that's seen. Is that a symptom of a sick disc level, a sick motion segment, or is that a real reherniation? That's really hard to tell. But it accounts for disease occurring at the originally operated level in somewhere between 21 and 34%. Unclear etiology. So look retrospectively at 28 patients with recurrent herniation, trying to do, again, a redo surgery study. But in that study, they had a fair number of patients who had contralateral herniation. Actually, they had 7 of them. And when you look at the outcome of those, of the 7, 6 had outcomes similar to first-time surgery and similar to redo with ipsilateral herniation. So somehow, redo herniation at the contralateral level seems to also be an effective surgery. That is something that's often quoted as an indication for fusion because it's indicative of a sick motion segment, that this is a level that's fallen apart, redo herniation, et cetera. And I think that's the upshot of the whole operation here, of the whole approach here, is that these redoing the same surgery has very good outcomes, and it doesn't necessarily mandate a new approach. Factors associated with recurrent herniation, again, this is observational, mostly retrospective, but seems like male gender, smoking, trauma, and degenerative disc at the initial surgery were predictive, not very strongly because of the nature of the data collection. Prediction of unfavorable outcomes seems to be duration of relief less than 6 to 12 months. If they didn't get good relief from the first surgery, they're a whole different population of patient. That's not so much a reherniation as perhaps another problem. Indications for fusion in the case of recurrent herniation. Obviously, if you get post-op segmental instability, your dull kerrison kind of took out the pars and now they have a slip. That kind of thing, but that's a different disease. Severe back pain component or a new back pain component, that's unsure, and then the failed back surgery syndrome, run away. Whether or not that surgical outcome is effective, and that is unclear. Clearly, there is some surgical indications, and we do see this to some extent. So, I mean, based on summary of what's strongly class 3 evidence, for recurrent herniation with pain-free interval, redo discectomy. Pretty straightforward, no indications really for anything different. For recurrent herniation without a pain-free interval, redo discectomy, but with lower expectations. Not that anything different is going to make a bigger impression. Recurrent herniation with instability, probably that's the small population to consider fusion. And then failed back surgery syndrome, epidural fibrosis, that's probably not an operative disease. Thank you.